Welcome to Clinical Unfiltered. That's right. Give me your hearts, your minds, your teeth, and let's get unfiltered with, I got Dr. Mark McCawley back here. Actually, he didn't go anywhere. We're just separating out this episodes and I'm making him record more.
I'm wearing the same shirt.
For all your purposes, it's been a week. It's been a week. We wear the exact same clothes.
Well, I do wear this shirt basically every day, just different versions, but
Guys, so last time we were talking about using an Nd:YAG laser, and we were mostly referencing the LAPIP protocol. But when you have that laser, especially what it was like a $90,000 laser, $100,000 laser, just to use it for periodontal therapy, sometimes it's hard to justify the ROI right away from something like that. But I will tell you, for me, I have it in my operatory for almost every procedure I do. I do a lot of implant-based therapy, and they have a term for that. And I keep freaking forgetting it. And I was like, I just repeated it 3 times with Mark, and I've already forgotten it. What are those added value procedures?
VAPS. Yes.
Yeah, you can't call it AVP. You can't call it Alien versus Predator. Got it. Okay, so it's VAP. Yeah. It's VAPS.
AVPs. Yeah. No.
Gotcha. Okay, so value-added procedures, which I do think is really what takes it to the next level for me. Because I'll tell you, I upsell using it for other procedures. And probably the most other place that I do use it is extractions and extraction sockets and peri-implantitis for the LAPIP protocol, which we'll get to in a second. LAPIP. We'll get to that in a second. But the sockets are probably where I use it the most. And you said you use it for socket degranulation too. Yeah.
If I'm taking out a tooth and the laser is available, that laser is being used in that socket because not only does it disinfect, because, we did the study, it disinfects pockets. It makes sense that it would also disinfect these sockets here too. So pockets and sockets.
Gotcha. Pockets and sockets. Well, let me ask you this. So, most of the granulated bacteria that are in sockets, are they still of that category of being like pigmented and...
as far as the bacteria, it all depends on what the reason the tooth is being taken out for. If it's perio, then yeah, it's the same exact stuff. If it's endo, then it's a little bit different. There's definitely some different bugs in there, but all the same, it's still going to kill the bugs because that's part of what people are afraid of now is leaving these. Oh God, I forgot what they call it, but it's like when there's a little reservoir of bacteria there, and then you if you don't disinfect it, you don't remove it, then the body kind of encapsulates that, and it creates just a constant kind of leakage and inflammation there.
Yes, I know I know the term you're talking about.
Yeah, you know the term. I'm blanking on it right now, just like the VAPS, just what you were doing. But so
guys, it's nighttime right now, so me and him are pretty spent.
It's been a long time.
I remember holistic doctors refer to it a lot. It's when it's this dead zone.
Cavitations.
That's it.
That's what it is. Yes. Yeah. So yes,
and you know what?
It's the same thing.
I buy into that. I do buy into that, especially since we're grafting a lot nowadays. I feel like the number one reason I rotated through a lot more general dentistry offices than you did. And when I would go in, I would have to do the implants after the fact. So they would do the extraction bone grafts, then it gets passed to me to do the implants. And I would open up, and I'm like, all right, it doesn't look like this. My bone grafts. I made them use the same material. It's still very granulated. Yeah. And I often wonder, how well did they disinfect or degranulate? Because sometimes it can be very hard. If you have a hole that's at the base of a tapered socket, and then it gets bigger at the apex, the chances that you're actually spending enough time to scoop out everything is low. Oh, yeah. You probably have something still stuck in there, and then you're shoving foreign material on top of that.
You're just throwing basically special sand in there, and then
you're feeding the bacteria. You're like, hey, I know you guys were munching on that natural bone. Try this unvital, but this non-vital bone
in there. Yeah,
it's got less immune cells. Enjoy.
Yeah,
enjoy.
It's gonna be great. It's gonna be great.
So tasty.
Yeah. So that's where the laser really shines because. I take out teeth and then I degranulate. I spend way more time actually degranulating than I do actually taking the tooth out, generally speaking. So I'm sitting there scooping. So I try to get all the pieces out that I can possibly reach, but I know I'm still not getting everything. So that's where the laser comes in. I flush everything out with saline and stuff, and then I get that laser all the way down right to that little endo defect right there, that little, basically a periapical lesion. Disinfect that, so I make sure that there's nothing in there, and then I coagulate the blood there too, so that way it kind of helps seal up a bit. And then I do a lot of PRF too, and then that actually has immune cells in it, so you've got some cells that are actually going in. So that's why, knock on wood, but I don't have like extraction socket infections like was much more common in residency when we didn't have all the fun tools to use.
Let me ask you this. What setting are you using the laser at to do the disinfection?
Yeah, it's the bleeding hemostasis one. So, it's kind of a dual action because I want to disinfect, but I also want to get hemostasis there too. So I want to basically biostimulate that, and it does even have a biostimulatory effect to the bone as well. So you're gonna stimulate the stem cells, you're gonna kill all the remaining bacteria, and you're gonna create this super tough fibrin clot down there at the base. So you're gonna get like basically a really good result where you wouldn't be able to if you just took it out and just threw some bone in there.
And in theory, this is the thing. It's like there's times where degranulation, like let's say it gets close to a nerve or gets close to the sinus, like you're poking through, like, okay, if I scoop this out, there goes the sinus, like I'm going to blast through the sinus. Those are actually where I almost like I stop scooping and then I just start lasering the heck out of it with the hemostasis setting in hopes that, yes, even though I'm not taking that physical tissue out, I've at least ran the laser through it, killed as much of it as I can possibly do, and still got some kind of seal over there, some kind of seal before I enter the sinus membrane. So if you find yourself running into sinus issues a lot of times, you don't want to leave it there. You don't want to shove bone graft against it unless it's been cleaned some other way. The lasers where it's really changed the game, especially in those scenarios. Again, I use it on every socket. Even if I felt like I've completely cleaned it up, I know the nature of what we're battling against.
No matter what, there's still going to be bacteria in the pores of the bone, basically in the,
unless it's freshly cracked tooth. Most of the time, these things have been endo-treated, and there's probably been a periapical infection for like 2, 3, 4, 5 years. Let's be honest. A lot of times,
these things don't usually happen overnight here. It's something where it's a chronic infection. So the body's just kind of adapted to it. But the problem is by adapting to it, you're still getting that leakage of bacteria. So you've got to use something that actually emits out. And then, again, the benefit of the laser is it emits out. So you don't even have to directly touch it. It still kind of gets some bacterial kill.
Like the laser tip doesn't, like, for example, the sinus scenario. You don't have to stick it and jam it all the way to the edge of the sinus, like, you don't have to perforate the sinus. You can. No,
I try to. If I see something there, I will touch it with it, but you don't want to poke it through the sinus through. There, obviously.
But you could do if you pushed it hard enough.
Yeah, you can definitely poke it through if because it's a fiber optic cable. You can poke that through things if you really try hard enough. But again, same thing with nerves. Like nerves, if I take out a tooth and I know it's close to the nerve, like I will measure it out on the CT scan, so I know exactly how much I've got. And I kind of measure the laser, and I'm like, okay, that's exactly how far I'm going down because I don't want to actually touch the nerve with the laser. You want to kill the bacteria around the nerve and stimulate it a little bit, but you don't want to touch it and fry it there. Too. You want to be very careful.
Yeah, definitely don't want to scoop it, and you don't want to overdo it with the laser. But I feel more comfortable going in with a laser than going in and just
100%. Because scooping, again, that part of the thing is I measure the scoop too. I'm like, that's how deep I can go in. I'm like, I'm not going any deeper because the last thing you want to do is hook that nerve and then try to scoop that out because that'll be a very, very bad day.
The first year I got my laser was the first year on record that I had zero. I mean, it was freakish. Like normally still I should have some complications just from the nature of the patient's own body, Yeah. I had zero implant complications, and I became superstitious at that point. I was like,
now you're like, no matter what, you're using
the laser has to be there, and my staff knows. So again, it's a part of creating the systems for it. My staff knows I'm doing something extraction oriented. I'm doing the periodontal therapy is very obvious, but if I'm doing an extraction or extraction suddenly comes onto the plate, the laser gets rolled in for that.
The laser gets rolled in. I buzz them. I'm like, laser in here. Same thing with the all-on cases. Like the laser, when I start an all-on case, when I'm extracting all the teeth, placing all the implants, the laser's in there before the implant motor is. So I take all the teeth out, I use the laser, I disinfect everything, and then I'll swap it out for the implant motor, and I'll start drilling for the implant. So they know the first thing that's in there is the laser. Then the implants are secondary. You got to disinfect everything first.
Correct. You know what? I also run it into my osteotomies, especially on the all-on-X cases, because a lot of times I'm going through multiple sockets. And again, there's just on these all-on-X cases, these full arch cases, there's just so much bad juju all over the place. You know, like you're bound to just bump osteotomies through old infections. It's inevitable. And I feel like having the laser run through the osteotomy to give me that extra verification that I've cleaned it out before the implant goes in. There's a protocol for that. Isn't there an acronym for that? Like running it through the osteotomy with the Millennium laser?
So they've got one where
I want to lift blast. What's the blast? Yeah.
So essentially what blast is you take the implant, and before you put it in, you actually run the laser over the implant surface. So you remove the oxide layer. So it's basically pure titanium that's showing right there. And then you can put it in, and then it becomes hydrophilic. So all the blood and everything like soaks into it. So you essentially turn any implant into like a SLA active surface kind of thing. So it's basically super hydrophilic because there's no oxide layer on it. You essentially blast the oxide layer off, and then you're able to put it in.
Gotcha. Okay, interesting. I did not know that. So have you done this before? I've never done that.
I've done it. I've done it a couple times. Like it's just logistically, it's kind of difficult because my operatories aren't huge, so I've got to either pick the laser or the implant motor. It's tough to have both in there and using them both concurrently. So it's just, the laser's not a small thing.
No, but I do have room, so I do have typically both of them in the room at the same time. What's the setting? Is that hemostasis setting again?
I don't have it's not like I have a high implant failure rate. If I noticed there was an issue where I had implants failing, but again, knock on wood, that doesn't happen. It's like once in a very, very blue moon that'll happen. But yeah, it's, if I notice that being a problem, then you bet your butt that would be the first thing that I would do for every single case.
And I run it when I am doing my extraction socket grafts, I'll run the laser at a light ablation setting. I'll run it on neighboring teeth too. Hey, these guys are close by. Let me make sure this sucker's clean. Yeah, it's numb. If it's anesthetized, I'll run it. And you know what? Honestly, so that I think it all boils down to that. If you can get a clean socket graft, and then your next step is the implant in that very clean area. Oh yeah, you're probably gonna have a better
you're gonna have a great implant. If you've got a crummy socket graft with a bunch of tissue in it, and you're not sure if there's still some bacteria at the base, then you're gonna have some issues there.
And I don't think people really correlate a lot of that. A lot of times they're like, oh, the patient didn't. I had a friend who would always be like, they're licking it with their tongue. I'm like, why? And I would treat the same patient then later, and I'd be like, look, I didn't see any damn licking. It just looked like, the graft had a hard time healing. Maybe it wasn't, something didn't happen for your implant to not take, and me to then work on it and then it take. So, I mean, I do feel like that people don't pay enough respect for that. And that's a great added function to using lasers is cleaning those sockets. Then I graft. I use a lot of platelet-rich fibrin. And I'm gonna get Myron or Dr. Estrin onto another podcast to talk about this. But they have this warmer for platelet-rich fibrin that'll almost make the platelet-rich fibrin membranes last longer, like a barrier membrane. And what I found is that actually utilizing the hemostasis setting on the laser will almost do some of that similar function at warming up the platelet-rich fibrin. And I know you can actually do this. If you don't want to graft every socket, for example, a full arch case, there's some sockets you really don't care to graft, or they're too small to graft.
You don't need to, but
you can hemostase the socket and have a clot fill and stabilize really well. I almost do that. I almost don't graft much anymore on my.
It's like a thermolytic fibrin clot is actually what forms if you use a laser on a certain setting there with enough blood in there. You'll get this red, kind of dark red clot, and it's much, much thicker than a traditional clot. So it's thicker, it's more robust, it stays around for much longer too. So, it'll start to, after a few days, it'll turn white. It's almost like a scab, it kind of looks like a scab. and it serves a very similar purpose there too. So that's why, I mean, again, if there's a socket where you're not grafting, you could just basically get some great hemostasis and you'll get some fantastic socket healing right there.
I think that's what people forget a lot of times with socket grafts is the whole goal is to create a super stable blood clot. Like that's like to get native bone. We don't really want like particulate. We want just native bone. And a super stable blood clot will actually do that. Maybe you lose a little bit of dimension, but you just want native bone. You really need vital bone. And so I think that's a great use of it too, is like sockets, like maybe a third molar you don't want to graft for any reason. You just want to stabilize it with stabilize that blood clot with the hemostasis setting. That's a great added use for it. Like I said, the platelet-rich fibrin membrane to almost make it more like a membrane on top of a socket graft is another great. And I've noticed that the 1 week post-ops, they're still hanging around longer than 1 week I normally don't see it, and I'm starting to see it at 1 week. Another thing too that I use it a lot for, and I think it's worth talking about, is the LAPIP protocol, like peri-implantitis. LAPIP.
I love that you call it LAPIP.
You know what? I've actually, now that I'm thinking about it, I think I've told patients LAPIP. I've been saying LAPIP.
Oh my God, you've been saying that?
I've been saying it like it's the thing. It's the right thing to say. And I was none the wiser.
It's the French coming out,
I'm going to pretend that that's still true. I'm going to pretend it's not LAPIP.
LAPIP on you.
So what does that stand for? What does it stand for?
It is LAPIP, but if you want to call it LAPIP, that is perfectly fine too.
What does it stand for? What does the acronym stand for? Because I don't know.
You don't know. You see, you're terrible with acronyms, so I don't know why they tell you these. Laser-assisted peri-implantitis procedure. So LAPIP.
Gotcha. Okay. How is it done? Can you kind of explain the steps?
It's very similar to the LANAP protocol, except it's around implants with peri-implantitis or peri-implant mucositis, which is a little bit different. The settings are a little different. You got to be careful with it because if you've, just for fun, take a piece of titanium and then put that laser up against it, it'll heat it up pretty quickly. So the name of the game is heat management, because it is the best thing in the world at disinfecting titanium. Like it'll basically disinfect down to the micro pores that they put in the titanium there, because they've sandblasted it, etched it. They've done everything possible to make this the most porous, bacteria-friendly surface possible. And then, you need to do something to disinfect it. And if you put a laser up against that,
great for attaching bone, but it's also great for attaching bacteria.
Bacteria love to do that. It's almost like you just start off with like calculus in there. So once the bacteria get into those micropores, then you've got to get them out. And honestly, traditional antiseptics and scaling and things like that, good luck. They've done tons of studies, and pretty much everything is like below 50% success rate, like long term, if you're not using something like a laser to disinfect. So if you use the laser, it's like much higher. It's like 85% success rate, which is double at least what you're going to get with any other treatment out there. So it disinfects better than anything in the world. And it also, kind of like what I was talking about, part of the problem with the implant surfaces is they kind of get corroded again, and then they end up developing that oxide layer again. So if you're able to remove that oxide layer, you basically refresh that implant, so that way bone likes to grow onto it again. So that's another thing that you can kind of, help the healing and kind of expedite the healing process and get regeneration or bone fill in these cases here.
Yeah, if you really want to see some crazy regeneration, look up LAPIP, LAPIP protocol, and they've got some pretty crazy regenerative results. I've got a handful myself.
I know. No, I mean, I've got some great ones.
I don't always get it. I think it has a little bit to do with the defect in the bone. Like maybe like a lot of times it's like if the implant's positioned perfectly in the center of the bone and the defect is completely circumferential, when you stabilize that blood clot, you have a chance of actually regenerate and disinfect the implant. You can regenerate. But a lot of times, I mean, I guess that's part of the problem is a lot of these implants are too facial or too lingual, or the soft tissue's too thin, and you don't have a perfect saucer-like defect. Yes, you can get it clean, and yes, you'll still get good results, but you won't get as much, per se, bone regeneration in a lot of those cases.
So, I mean, I think that's why the success rate on implants is like 85%, where if you look at teeth, it's like 98% success rate on teeth. So, I mean, the discrepancy is an implant is not a tooth. An implant can be facially positioned. It can be tissue level. It can be bone level. It can be, maybe they've got this big wonky crown on it. So like there's a lot of variability. Yeah, sometimes it's too shallow. So like there's a lot of variability with implants there that you don't get with natural teeth. So, just the fact that even the attachment's different. Around a tooth, you've got the periodontal ligament. You've got a lot more blood supply, things like that, whereas an implant is literally just fused to the bone. And when that bone kind of peels away, you've got to somehow stimulate those stem cells to regenerate and refill back in.
You're asking a lot more, I think, in bone regeneration around an implant from a blood supply standpoint. I mean, the PDL is such a beautiful realm of cells to generate, even though it is hard to regenerate periodontal tissues because it's a lot of attachment apparatus to regrow, but it's still around an implant that's failing or losing bone, it's hard.
You've got less stem cells to work with. So, because again, the periodontal ligament is chock full of stem cells. So the bone, you get some, but you don't get the same amount. So you really, you can get good bone regeneration with it, but it's more unpredictable. I do find myself doing a lot more bone grafting in these LAPIP cases because I kind of like a belt and suspenders. I want to know that I'm going to get some bone regeneration there too. So I will disinfect that implant with the laser, completely disinfect it, and then I'll actually end up using basically the PRF bone in that socket or in that defect to regenerate as well. So, I'll kind of do a belt and suspenders, and I've been getting some fantastic results with that.
So flapping open.
I'll kind of do like a mini flap there. I try not to like do a big, like massive flap. I used to do a lot of that, but more recently I've been kind of trying to keep it more conservative and just kind of opening up a little bit there just so I can access it, remove all the rest of the granulation tissue there, or granulomatous tissue, and then I'll pack the bone, try to seal it with a membrane, and then suture on top. I'll try to do it as minimally invasively as possible.
When you're treating it like that, do you put back the restoration on it or the crown on or the healing cap, or do you not take it off?
Remove the restoration as a general rule because I don't want to strip a screw. I don't want to break something. I don't want to put it on wrong. There's, once you start getting into the prosthetic aspect, you've got a lot more variability, a lot more issues there. I will generally just work around it as long as I can get access. Like some of them are just too bulky. Like, for instance, if it's like a full arch, like all on four that's just got like massive buccal flanges on it that there's no way to get to, yeah, that one I'll take off. But if it's a regular crown or a bridge, like no, I don't need to take that off. I can work around that all day long.
So I'm going to counter you on this. So I've noticed it depends on the implant. It does depend on the implant. Implants that are like flat internal hex implants. Like they're just BioHorizon, Zimmer. Well, but BioHorizon has a conical connection too.
Yeah, now that
the new trilobes. Yeah,
but the older BioHorizon.
Older ones, yeah. I mean, it still exists. It's just there's ones that are just internal hexes, no conical connection to them. Mm-hmm. When I take off the restoration in a peri-implantitis scenario, often, especially in a molar, I'll open it up and it smells like a trash can in there. It looks like a trash can in there, like inside the implant. And I'm like, how is this crown that hasn't been moving? It hasn't been, it hasn't moved. It's not loose. I took it off myself. How is it still developing all this buildup inside the implant on these? And I do have a theory that some of these connections do flex a little bit. Let's say they get a new crown on the one side and now their bite shifts and now they're overloading the implant. So it's definitely an occlusion-based problem, but it's flexing that and allowing micro leakage to get into the implant. And then you're getting this anaerobic environment, and then it's just spewing back into the tissue and it flexes again. And then you're developing maybe a peri-implantitis 10 years down the road, rather like it was good for 10 years and all of a sudden, boom. And if you track back, I bet you can find a crown that's changed, like somewhere else. Track back. I want you to look back on it. You'll notice something like that changed. And then in those instances, I like to actually take it off and like flush the heck out of it, clean the inside out. And I will actually, from a distance, use my not directly in there. I won't stick my laser like all the way in there because you'll go pop, 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 pop. Yeah, no. So yeah, from a distance, I'll run it and flush it the heck out of it, and then put the restoration back on, torque it back on, and then take it almost out of the bite. So that can't hit that micro lesion. Those results I've been getting. What I hope for is that those will be better long-term results. Now, this is something I started doing like maybe a year or two ago. When I first noticed, when I took it out, and what again? It was an implant crown that wasn't loose.
Because that's
And
the
I
thing. Like
noticed,
theoretically, it should be a sealed, as
correct.
well
Yeah,
sealed as possible.
it's
Because
a new theory I'm working on,
if you
guys.
leave anything in there, like because you get blood and saliva and things when you're screwing it down, so like that gets sealed in there. If that's sealed in there for a few years, like it's gonna just be a rotten mess when you open it back up. Same thing with like crowns.
Yeah,
As soon as you cut off an old crown, like sometimes it just stinks. It's
stinks,
just like
how much has it been leaking?
it's supposedly like this sealed apparatus, and like you sealed in like gunk. So it's
Well, then it's being see, my theory again. Theory, it's being fed, and I
Yeah.
mean Kyle DeLuca, he did
Yeah.
that study with the Astra implants, where it's like we went in to see how much micro leakage, and there's a lot of research that supports different implant connections creating different amounts of leakage. And I feel like a lot of what I see is late stage peri-implantitis, like did good for a while and all of a sudden changed, has to do with some kind of load based issue. This is something I got to work on, but again, theories, guys, theories.
Let's do that study, man.
But even
Let's
then, like you're right. When I flap open, I still use the laser. So my laser still. I always tell patients it's still the best tool I'm getting to be able to disinfect. But I'm not aiming it right at the implant surface. Like I'm almost running it parallel to the implant surface.
I mean, if I'm able to actually if I'm able to get access to it, I will turn the laser down so it's not like crazy high, and I will aim it directly at that implant surface and then irrigate as I'm doing it. So that way I'm able to get that. It'll basically, because you'll see, it'll actually resurface the implant. When you're aiming it directly at it, I'm trying to go all the way around it. You'll see it kind of turn to a different color gray. It's almost like a lighter gray color right there. That's the oxide layer being removed. And if you're just doing up and down, you may not be getting all of the surfaces the exact same way. So like at a certain point, like I like to irrigate and kind of basically hit it. Like I will actually hit the implant, but irrigation is key. Don't just start hitting an implant with a laser because you'll cook the thing. You got to be very, very careful.
What setting do you aim it at?
So I will do the ablation. So it's going to be 100 microseconds. And then I will do I'll do like 3.2 watts usually.
Oh, okay, interesting.
That way, like, because it's not going to heat it up. If you're doing like 4 watts or something, you'll cook that thing pretty quick. At like
I heard that's a technique if you want to remove an implant.
Nearly as much energy, so you're not able to, you're not going to get the same speed of heat. And I'll bounce around like my LAPIP cases. If I've got anything else, I'll do the implant and I'll go do something else. I'll let it cool down. Then we'll spray with water and then we'll let it cool down. We'll do something else. Then I'll come back. I'll do a little bit more and then spray with water and then I'll do a little bit something else over here. So like it's one of those things
Curious
where
is what you're doing over there.
heat management is a huge.
Go back to your microscope over there.
You gotta know what you're doing when you're treating these. You can't just be just slinging the laser around hoping for the best. Because
right, you don't want to be popping the implant at high settings because you will. You can disform the metal on there. You can be, and it will spark if you start hitting the implant.
That's why settings are important. That's why again the Millennium is the best laser for that. So you can kind of tweak with your settings and make it so it's the most effective.
There are like, what is it? I think the CO2. There is a laser or erbium YAG. One of them where
the erbium. I think it's erbium chromium YSGG is one of the ones that they they talk about as being able to do like implant disinfection or like they haven't done any studies on disinfection, so like they don't actually know. They just know that it's able to remove calculus and stuff. So I mean, again, I'm not sure how
you can use it
is
directly on the surface. You can be a little bit more lax on how much.
Yeah, you can be more lax with that one. That one because it's more reflective. Again, wavelength is huge here. So the problem with those is it's absorbed by saliva a lot more. So like you can't get through saliva. The good thing about the Indie YAG is that it just goes right through saliva and it'll hit whatever. So it's not absorbed by water or anything like that. So and again, same thing with like tissue.
You would need to have a cleaned site or direct access.
Yeah, so I mean,
dried up to be able to use.
Yeah, you'd have to have it dry so that way it won't get absorbed by it. So.
Gotcha. Okay. Yeah. I use it on my mucositis
that is a laser
cases.
that they market heavily for using on implants.
For
again, it's good in some ways, but I don't know how well it actually works on that. I I know that the Indie YAG resurfaces it, and if you're careful and if you know what you're doing, then you can get a fantastic result with it. And that's just what I do on a near daily basis with the implants. Yeah,
I'll tell you, on those cases that are like, again, I know it's too facially inclined where I'm like, no, bone grafting is going to do so minimal. Those are actually some of the areas I love it the most because I'm like, look, this is probably the best shot. We get, like, I'm going to clean it. We're not going to probably get that much bone regeneration, but you're going to get to keep your implant a little bit longer. We'll try to reduce as many.
Kick that can down the road. So
unless they want to remove it, of course. But then the other option too is a lot of times if it is facially positioned, often, especially in the lower or upper posteriors, it's a soft tissue problem too. So like I'll encompass cleaning it with soft tissue grafting rather than bone grafting, unless it's like
I love doing some tissue grafting, especially if it's like an anterior or something like that. Like you got to do something because a lot of them they place too facially, and some of them even hurt too because literally you've got some of the facial tissue or just tissue in general rubbing on like a thread. That doesn't feel good because those are essentially threaded screws with most of them. So if you've got tissue rubbing on a thread, you've got to do something about that. You can't just leave it. You can disinfect it, but if you leave tissue rubbing on the thread, you've got to do it. If it's like in the posterior, I'll do like a gingival graft, so that way we've got some decent attachment around there, so it's not going to be mucosa rubbing up and down. I'll do like connective tissue grafting, get some. We try to make it as aesthetic as possible, considering the bone loss. So.
Yeah, I mean, in the end, it's still like all these different variations of it. I do end up using the laser as my main disinfection tool, and I have noticed better disinfecting results.
Implants, I mean that laser is going to be the best thing on the planet. I mean, I don't know anything that's better. If there is, somebody let me know, and I'll buy it tomorrow.
It's been a problem that we've all struggled with for a very long time, as far as like trying to come up with the best protocols to it, and it's like we're just end up throwing the kitchen sink, but. In the end, I feel like a lot of the cases that I've just run the laser, especially the mucositis cases, I feel like I've been able to thwart a lot of problems by being like, hey, let me utilize the laser to clean it. I know it hasn't like caused significant damage, but it's starting to show signs of it. Running the laser through that pocket is a great way to kind of stabilize the situation around an implant.
It's funny. I think I read a study. I think it was just under half of the implants at 10 years. I think it was like 46% of implants at 10 years, they have peri-implant mucositis. And then I think it was like 20 something. It was like 22% or something like that.
It's a way bigger problem than any implant company wants to admit.
Yeah. No, I mean, nobody wants to admit these things, but like a vast majority of these implants are not healthy. Like they at 10 years, they said it was like basically only a third of the implants were actually healthy. So this is not a small problem. This is a ubiquitous problem. Almost all these implants. Sorry
to like everyone who's hyped up to start slamming implants, and you just got to be ready. It's an inevitable future of dental implants. There are a lot of them they're not going to last forever. Don't ever tell a patient that. So, but be ready to manage it. Like that's the thing. I feel very confident when I run into peri-implantitis, and I'm like, I got this. And I'll tell you, sometimes I have some early stage issues where it's like, something is starting to happen. Not often, but if I do, I've hit them with the laser and I've been able to nip them in the butt. And like if I see them at the 1 to 2 week post-op and I'm like, hey, this is funky, run the laser on it. And all of a sudden 3 week post-op, it's gone. I'm like, oh yeah. Let me ask you, do you do any depigmentation with these lasers?
I love depigmentation.
Okay. You do. Interesting.
I love depigmentation. Now, honestly, those are some great cases too. Cause like, the before and after, and it's like almost a near immediate result is absolutely fantastic. So,
like, let me ask you this, because I know it gets picked up in pigmentation really high. Does that make it one of the better lasers for depigmentation, or all the lasers do depigmentation?
It's got to be one that's attracted to the melanocytes. So again, dark pigments, and that's where that 1064 nanometer wavelength comes into play right there, where you're able to basically zap the pigment and you don't just burn a hole through all the tissue there too. So it basically just zaps the melanocyte and then it leaves everything else pretty well intact. So you're not just cutting things away or just butchering anything. So it's very specific.
When you're doing a depigmentation, are you like running it along the surface of the gingiva for an extremely long period of time?
Yeah, so basically, anywhere that's dark, I'll run the laser over, and it kind of just basically it'll get rid of those melanocytes. It just basically ablates
like
the
an
melanocytes.
upper arch. How long does it take?
I mean, that's the thing. It does take it takes a little while when you're using a laser, so it's one of those things where you kind of got to go over it. And I'm kind of a perfectionist when it comes to that too, because I want to make sure it's gone and it stays gone. So like I'll go over and I'll kind of come back. I'll like wipe it down. I'll be like, all right, there's a little bit left. I'll do a little bit. So like it's an art more than anything else.
And you're waiting for. I actually haven't done any purposeful depigmentations. When you hit a specific spot long enough, does that just the darkened spot turn light pink? Is that kind of like your signal to say, hey?
Yeah, it just basically like ablates it, and then like it just kind of it'll kind of turn dark a little bit, but then you wipe it off, and then it'll be pink underneath. So you'll get you do get a little bit of bleeding from it, but it's just superficial. So like just it's a little bit of gauze, and then it's fine.
Post-operatively, Motrin 800.
Yeah,
600.
I mean, honestly, I'll give 600 of ibuprofen, and then that's they
like
don't need much
a day or
more
two.
time.
Are they like uncomfortable for 3 days? Is it like an FGG? Like
No, God, no.
Okay, yeah.
It feels like they got a burn on their mouth, but it's one of those things where it's like a pizza burn kind of thing. You eat a hot piece of pizza, you burn your mouth. It's gonna be like that, except kind of around those areas. So for the first few days, it's going to be uncomfortable, but it's not going to be like excruciating. You're going to be able to eat.
It's a soft, modified diet, liquid diet, or
relatively soft. They don't have to be super soft with that because you don't have to worry about it like really upsetting anything. It's not like you need a clot there because it's all just kind of just there. It's the tissue's kind of just thickening back up again.
How do you get the patients for this? Like, do they come in asking for it, or you?
Yeah, no, I mean, it's one of those things where I market that sort of thing. You go to my website, and it's one of the things where it's one of the things that we do, and we'll market it because there's a lot of people that want that sort of thing, and there's not a whole lot of people that can do it well. So beautiful to be able to do that. And
how much do you charge for is it a whole mouth or per arch?
It's basically it's kind of like usually we divide it up into like quadrants usually.
Okay, gotcha. You like what's the code?
I don't know codes, man.
No, not like numbers wise. Like, is there like, do you just say depigmentation, quadrant? I
mean, how I write open my notes is like, yeah, depigmentation, like upper right, upper left quadrant. Like I'll kind of write it up like that. So
I'm just curious because I wouldn't even have a clue how to like charge a patient for us or like what the market is charging patients for depigmentation.
I'll talk to my front desk. I'll text you tomorrow about it. But yeah, like I don't even know how much I charge. That's the thing. Like I let my front desk deal with all of that because like honestly, my happy place is doing great work on patients. I'm like I let my front desk people deal with everything.
We'll leave it on a hang cliff. If people want to know how much they need to charge, you will then call Dr. McCawley's front desk.
Call my front desk. They know. I honestly don't. Like, I'm the worst person to talk to. Like, the patients is like, oh, how much does that cost? I was like, I don't know. It's like, let me just write up that treatment plan for you, and like, I'll let you know here in 5 minutes.
You practice the ignorance so well.
Yeah. Yeah. It's like I don't know. I'm like I like the delegation aspect of that because like honestly, I'm terrible when it comes to like money and stuff. It was up to me, like everything would be free and like I'd just be doing all this like beautiful dentistry for free, but you can't run a practice like that. So thank God I have like good people that work with me. So yeah, it's one of those. It's one of those. And I mean, there's one thing that you forgot to mention, biostimulation.
Oh, biostimulation. That's right.
Biostim. So
what are we stimming?
What are we stimming? So basically it's one of those things where you're stimulating the cells. It's nerve cells, it's the fibroblasts, it's everything. So if you've got someone with like swelling or pain and you hit it with the biostimulation setting on that pain and swelling is going to be less. So I've done it on patients where, I'll do like a bigger surgery. Like normally it's like a ridge augmentation and those ones generally are sore. I'll try to do a little biostim at the time. But if they come back at a post-op and they're like swollen and kind of hurts, then I'll spend some time and I'll go over it with the laser for like basically like 5-10 minutes or so. And then it's a decent amount of time. You'll sit there, you'll biostim it.
On the outside and inside or just the outside?
I'll do outside and inside. And they'll tell you kind of how it feels because you want it to feel like almost like a warm breeze. You don't want it to be hot. If it's hot, you're too close. You need to back off. But if it's a warm breeze, that's where you want to do. And I've got a buddy who's out in California who uses this for nerve regeneration.
Good success. He's like, this is his thing.
He's had ridiculously good success with it. Like, he told me some of the numbers, and I was like, no way. Like, these are some people that have been numb for like years, and they come in, and then he's able to actually get like a decent amount of nerve stimulation where they can actually feel now and, get some use out of that area. So
I'm interested if they would code that like medically.
Again, you're talking about code, man.
No. This is the business side. This is the dental unfiltered mind of mine kicking in. I'm just curious as like how you would implement.
I'm the mad scientist. I'm not the numbers guy. I've got somebody up front. They deal with like the codes and the numbers. Yeah.
It's trickled into me. I listen to the other side of this podcast.
You listen to the other side. Yeah, no, that's great. That's great. I probably should, but like, no. I like
the nerve regeneration. I'm assuming it's also then similar as you're just aiming on the exterior and interior using the biostim setting on the NDA. I'm assuming it's the NDAG laser.
Oh yeah, no, that's the
Are
NDAG.
they using that other fiber tips? Because I know there's different diameter fiber optics. Yeah.
So like the other fiber tip for the biostimulation, you typically just use the regular fiber tip. They've actually got an attachment for it that's a biostimulation attachment. I don't use that because I don't want to just take, it's a pain in the butt to use. I just use it, and I'm like, how's that feel? It's like, does it feel warm? All right, it feels warm. I'm at the right, like, distance from the area. And they're like, it's hot. I'm like, all right, I need to back off a little bit. So, like, you're close, but you're not too close. You're kind of just going over it, and you don't want to spend too much time in one area because you kind of overload it and put too much thermal energy into it. So you want to keep moving back and forth, and then you want to stimulate the area. And you kind of want to get to, if you think there's an area where the nerve has been damaged, you want to focus on that area because that's where you're really going to get the regeneration is from the damaged area of the nerve.
And as far as the nerve, like that same biostimming is kind of the same modality of treatment to do it on a nerve, like nerve regeneration. You're using the same kind of technique to
biostim is biostim. The good thing about the NDAG is it's literally got you just push the biostim button and it'll kind of set that to it. I'll tweak with it a little bit sometimes, but like generally I'll stick with the biostim setting. As far as like pain and swelling, I've got patients that like literally they'll come in like, after a surgery, they're super swollen. A few days later, they're like, oh, it really hurts. I'll put like the laser, I'll do the laser on it, and they'll call them the following day and they're like, oh my God, like it's gone. Like it immediately went away. Like as soon as I left the office, I was like, what?
Shocked yourself.
It seems like it's like hocus pocus, like fairy dust, like pixie dust stuff. No, like it actually works. Like it seems like you're doing absolutely nothing by just running a laser over it, but I'll be darned, it actually freaking works. So no, it's pretty cool.
I'm gonna start saying Harry Potter incantations when I'm like,
just like
messing with my patients. Facial hair, would that have any issue if you've got facial hair and you're running it like dark facial?
You don't want to spend enough time on that area where you're gonna like burn the actual, hair follicle because you can do some like, hair removal with it if you want to crank it up and hit the follicle. It'll hurt like hell. Like
because the heat would
numb up for that if you really want to do hair removal.
The heat would get so high on the
it's all
on the next episode we will be talking hair removal.
The value added procedure of hair removal. No. That's where I draw the line.
You have a line. Good. Guys, thank you, Mark, for hanging out with me tonight and recording another episode. And guys, remember, Mark, you are not getting paid for this. This is purely out of the love and passion.
Paying me?
No,
dude,
you obviously sound
man.
like you have to ask my front desk how much it costs.
Exactly.
I learned something.
You learned it, yeah.
Follow, comment, share with your friends.
Yeah.
And again, thank you, Mark, for getting.
Check it out. That's our website. I've got a YouTube. I've got a bunch of videos on there about basically like how to keep your mouth clean. Also about treating perio. What is perio? What these bugs look like. So I've got some cool stuff on there too. So check me out too.
Thank you, Mark, for getting unfiltered with us today. See you guys. Till next time.